Hello, I'm Ibrahim Imam, and welcome to this episode of the Neurology Lounge podcast. In this episode, we will continue exploring the interesting disease of myasthenia gravis. And today I'll be speaking to neurologist Nicholas Silvestri, author of the most accessible book on the topic I found titled Recognizing Refractory Myasthenia Gravis. Nicholas Silvestri is a professor of neurology at the University of Buffalo Jacobs School of Medicine and Biomedical Sciences, where he's also the Associate Dean for Student and Academic Affairs. He completed his undergraduate degree at Cornell University, received his MD from the University of Buffalo, and completed his internship in internal medicine, residency in neurology, and fellowship in clinical neuromuscular medicine, all at Harvard Medical School / Beth Israel Deaconess Medical Center. He's board certified in neurology, neuromuscular medicine, and electrodiagnostic medicine. Over the past several years, his research interests have included myasthenia gravis and inflammatory neuropathies. He has authored over 60 peer-reviewed articles, book chapters, and textbooks, and he has presented talks nationally and internationally. And hopefully he will add participating on this podcast to the list for the next time. Nicholas Silvestri, welcome to the Neurology Lounge podcast, and thank you very much for your time today.
Thank you very much for having me. Pleasure to be here with you and look forward to our discussion.
Excellent. Why did you decide to write this book, particularly on refractory myasthenia gravis? And I'm aware that it's a co-authored book. Where did the idea come from, and why the focus on this part of myasthenia?
Yeah, I was actually invited to write this book by the publishers, and I was very fortunate to collaborate with Dr. Pallas at Oxford on this textbook. And I think that the genesis of this book was really at a time in a crossroads in myasthenia gravis. We had been using very conventional, or as we refer to them now, conventional therapies, corticosteroids, broad spectrum immunosuppressants. And at that point, it was kind of the dawn of the new age where we were starting to have new targeted therapies for the treatment of myasthenia gravis, as I'm sure we'll discuss. And I think really the idea behind that book was to really outline the fact that though myasthenia is a treatable disease in many, if not in most cases, there are still patients that up to that point, and still to this day, to be honest with you, struggle with the disease. And it was really kind of a way to outline that fact and really talk about how we need more and better directed therapies for the disease so that everyone with myasthenia gravis can realize symptom improvement and have better lives.
Excellent. And how did you go about writing it? Did you share chapters, or did you collaborate on each of the chapters between the two of you?
Yeah, I mean, I think that it's been a couple of years now, but as I recall, I think I took kind of a first pass at it, did a very broad literature review, using pretty much everything that was available on the topic to that date. And being junior to Dr. Pallas, the way things work in medicine is I gave it a first draft. She touched it up, and we went back and forth a little bit and submitted it to the publisher, and thankfully it was found to be acceptable for print.
Good. Okay, I will not go into any controversies that might arise.
No controversies at all. It was actually a great collaboration.
What I liked about the book was that it went down to basics, starting from the clinical before going into the basic straightforward myasthenia. And even that kind of brings out a lot of interesting things, let me put it that way. And one of the things I wanted to start was with your comment that 2/3 of people with myasthenia gravis start with ocular symptoms, and 80% will go on to become generalized. What's the reason why the eyes are kind of the focus or the onset of myasthenia?
Yeah, I don't think we quite know. I mean, the two big theories are, first and foremost, if you think about it, we use our eye muscles continuously. In a disease like myasthenia, where the target is the neuromuscular junction, and the symptoms are worsened by action, I mean, we're constantly using our eye muscles, and so they can, frankly, fatigue easier probably than any other muscle in our body. The second theory, and it's probably a combination of the two, but the second theory is that the acetylcholine receptors in the eye muscles are different from everywhere else in the body. Specifically, they retain the fetal form of the acetylcholine receptor, whereas the remainder of the body eventually attains the adult form of the acetylcholine receptor. And we think this is important because the the fetal acetylcholine receptors that are on the eye muscles are actually a little bit more immunogenic. So they seem to attract the acetylcholine receptor antibodies a little bit better than the adult type. So they're probably attacked a little bit more as well. So those are the two main theories as to why ocular symptoms are predominant in the disease and why most people start with ocular symptoms.
My intuitive feeling was the eye muscles were the smallest in the body, but
That could be too.
I'm not too much off the track. Um, and the other thing which kind of in practice we realize is, and you mentioned that the severity of myasthenia gravis is not related to the level of the antibodies, which I found a bit surprising. What is it then that moves somebody from ocular to generalized, if we can't use the level of antibodies as a predictor?
It's a great question, and we don't know. I mean, I think to address the first part of the question, again, it's been well known that antibody levels don't tend to correlate with disease activity or the likelihood of generalization after ocular symptoms develop. It would be great if they did, right? Because it would allow us to kind of tailor treatment accordingly. But it's well known they don't, and a couple of reasons for that could be the fact that number one, what happens in the serum may not be with what's happening at the neuromuscular junction. So there may be more acetylcholine receptors, clustering at the neuromuscular junction, the point of impact, as it were, rather than in the serum. But the other possibility too is that the assays that we're using to date just aren't sensitive or specific enough. They're good for diagnosis, but they're not really allowing us to really understand disease activity. And so it would be great if we had a better biomarker, or maybe we have the biomarker, but we need a better assay to allow us, in combination with the history and the exam, use this assay to understand A, how a patient's doing with response to therapy, B, what their likelihood of generalization is if we have ocular only symptoms, and frankly, C, what types of therapies are appropriate for patients. We have a wealth of therapies in MG right now, and right now it's still a lot of art of medicine, so to speak, rather than picking a targeted therapy for a specific reason because we have no biomarker that allows us to determine that.
It's interesting for such a disease that is as ancient as neurology. We're still battling with the the basic things about biomarkers. Um,
Absolutely, absolutely. No, I mean, and I think we know more about MG than we know about a lot of neurological disorders. But I think that this is a classic example of we can't be complacent. We have to keep pushing and pushing until we sort this out a little bit further.
yeah. Well, we'll come into the aspect of the different types of antibodies as well. But one of the things that caught my attention, and I'm going to quote you there, that a distinct subset of patients have very difficult to control disease, and they constitute 10 to 15% of people with generalized myasthenia. Um, are these people fated to have treatment resistance, or is there something along the way that makes them end up as treatment resistant?
Yeah, it's a good question. I mean, I think that that data is a little bit old now. I mean, data is over a decade old, and I think it was prior to the advent of some of the targeted therapies that have been approved to treat MG over the past 7 years. So I suspect that percentage is lower. One of the great things that was seen in the trial of eculizumab that was published about 7 years ago or so was that it looked at patients with what were defined as otherwise refractory symptoms, and it showed in that particular trial that treatment with eculizumab helped many of them. So I think that there is hope for people that have refractory disease, or what has been defined as refractory disease, with some of the targeted therapies that we have available to us today. So I suspect that if we did another study now looking at the percentages of refractory disease, it would be lower. I don't think it's zero yet, but I think we're cutting into that percentage with these newer therapies.
Okay. Um, and without kind of very precise biomarkers, are there things we can latch onto early in the disease course to suspect this person is going to be treatment resistant, and we just jump to the current monoclonal antibodies rather than go through?
Yeah. It's hard, right? I mean, I think that time has really shown us that the major risk factor for severe disease out of the gate is probably antibody type, right? So those patients that have the MUSK myasthenia gravis tend to have a more severe phenotype, as evidenced by much more prominent bulbar symptoms, which can put people at risk for things like aspiration pneumonia and crisis. But other than that, I think it's really difficult to know. I mean, I've seen people, for example, present with respiratory failure as their first symptom, and as soon as you get them under control, they're great. They're controlled for years and years. I've also seen people initially present with what I would term relatively mild disease who very quickly become treatment resistant. So it's really difficult, and I think that my mantra in the treatment of MG has been to treat early and treat aggressively, because as seen in many other autoimmune diseases, and really there's some burgeoning evidence too in MG to show that that's probably the best thing for patients in terms of keeping them from becoming severe or what we would call treatment refractory.
Okay, well, that makes me jump to one of the questions I was going to ask later on, and which is people with ocular myasthenia gravis, which should be on the milder end of the spectrum. As a principle, do you use immunosuppressants in them, or are you happy to control them with just something like pyridostigmine?
Yeah, so with ocular patients, are a bit of a different breed, right? At least those patients that initially present with ocular symptoms. And, some patients you're able to control with pyridostigmine alone. And if that's the case, that's a huge victory. But I would say that's the minority of patients. Many patients with ocular myasthenia, you need to move on to corticosteroids. And I think that in those patients that remain ocular only, oftentimes you're able to really hit them with a decent dose of steroid and slowly taper them to something very small, like 5 milligrams a day, and keep them in remission for years and years. Now, granted, these aren't people that generalize. That kind of changes the equation. The unfortunate part about ocular myasthenia is that many of the therapies that have been approved are not indicated for patients with ocular MG, and it's not clear if they frankly work. So I think it's still an area of active investigation. I will say, though, that in patients that have ocular MG where I'm not able to taper their steroids to a reasonable dose, and I would say reasonable is probably 10 milligrams per day or less, because that reduces the likelihood of side effects. And those patients, I do try to transition them onto an oral immunosuppressant like mycophenolate or azathioprine to eventually allow me to taper the steroid dose further.
Okay, that's helpful. Then going back again to definition, one of the things that you used to define refractory myasthenia was those who are unable to take the treatments. Is that a bit of contradiction in terms of if they are likely to react to medicine and they don't take it? Why should that make them refractory if they haven't actually been on the treatment?
So it's a good question, and I think that what we were indicating in those cases, and I think, to be fair, it's a small percentage of patients who we would deem refractory, are patients that mostly have intolerance to the medications. So patients that, let's say, for example, I'll pick on mycophenolate for a minute, even though I think it's a generally good drug for myasthenia, that have very, very severe nausea, diarrhea. I mean, it might control their symptoms, but if they can't leave their house because they're on the toilet every hour, that's not acceptable, right? Or patients that develop thrombosis with IVIG. I mean, they've tried it, it might have helped, but to keep them on it is risky. Or people that have contraindications to those medicines. And so again, I acknowledge it's a small percentage of patients, but if you can't give those medicines to people, then they're not refractory because of efficacy, they're refractory because of safety or tolerability.
Okay. So it's refractory in terms of practical implications. We need to do something different.
Exactly. And I think that, that brings up a good point, right? When we're treating patients with any disease, but, talking about MG today, it's important to kind of take the whole picture into perspective, because if we in our silo have the myasthenia very well controlled, but we're causing a lot of problems with other medical issues, it's really not a win.
Yeah, the surgeons will say the operation was successful, but the patient died, kind of thing.
Exactly.
Okay. A couple of questions on epidemiology. One is the comment about whether the incidence or the prevalence of myasthenia is increasing. Is that still the case, and is there a reason why?
Yeah, I think, it probably is. And I think part of the reason is if you recall, myasthenia has a bizarre bimodal age distribution. So it can affect women more than men in their 20s and 30s. And then there's a late peak in the 60s or 70s where men are slightly more affected. And I think probably why the incidence and prevalence are increasing is because we're frankly doing a good job in medicine in general by keeping people alive longer. And so the longer that people are alive, the longer they are, susceptible to any disease, but that includes myasthenia, particularly in that late peak. I'm not aware of any data that suggests that it's happening more often in the younger population, but I think it's definitely something that's being kept in mind and being looked at.
And about the bimodal distribution as well, bimodal age distribution, those around the age of 50 tend to be mainly men, while the younger patients tend to be females. Is Most autoimmune diseases tend to be all females. Is there a reason why older men are more susceptible to myasthenia, or is there some?
It's It's a great question. I don't think we know, right? And it's a little bizarre, right? Because most autoimmune diseases, not all, but most autoimmune diseases tend to occur more commonly in women. But why it's happening in men a little bit more than women at that later peak is absolutely unclear right now.
A lot of work to do with epidemiology. And coming to pathophysiology, one of the things you talked about was this membrane attack complex. Um,
Mhm.
what 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 does that what is that, and what does it do in generating the symptoms of myasthenia?
Sure, sure. So the membrane attack complex is also called the terminal complement complex. And so basically, one of the ways in which the acetylcholine receptor causes damage at the neuromuscular junction is by attaching to the acetylcholine receptors, by activating complement, which is a series of multiple proteins in the blood. But when complement is activated, the terminal complement complex, which is C5b, C6, C7, C8, and C9, basically form a pore that punches a hole into in this case, the muscle membrane, effectively destroying the muscle membrane. And so when that happens, obviously neuromuscular transmission can occur and the symptoms of MG develop.
And that's all. Is that all set kicked off by the antibodies? Then that's the starting point.
Exactly.
Okay.
Yes, exactly. It's antibody mediated. Absolutely.
And in medical school, I only learned about the antibodies, but your book talked about the binding, the blocking,
Mhm.
and the modulating types of antibodies. Are these acting all together, or do the different antibodies kind of generate a different phenomenon in the patient?
Yeah, great question. So by far the most common antibodies that we find in patients are binding antibodies, and those are the ones that we think activate complement, as I just mentioned. The blocking antibodies do just what they sound like, right? They attach to the acetylcholine receptor and they physically block it. So think of it preventing acetylcholine from attaching to it, really blocking that ability to cause neuromuscular transmission. And then the third type of antibodies you mentioned is the modulating antibody. And those are antibodies that actually cross-link multiple acetylcholine receptors and they cause an internalization of the receptors and then they're degraded in the lysosome. So they're also effectively reducing antibody numbers. The amount of those types of antibodies differs from patient to patient. Frankly, it probably differs within the same patient at any point in time. But those are the three distinct mechanisms of how the antibodies work in MG.
It's almost as if they are collaborating, like an army trying to attack a different
Exactly.
locations, and interesting.
They each have a different mission.
Okay. We not the issue of MUSK. You mentioned MUSK myasthenia being quite aggressive. The other thing I found was when you said it's more frequent in Black people, and there's some association with the equator. What is the reason? Is that, do we know the reason for this? Is there any?
Yeah, no, I think that's an area still of active investigation. It's a little interesting, right? But it's not unheard of, right? If you think of a different neurological autoimmune disorder, multiple sclerosis, it's kind of the opposite, right? It tends to be more common in people of Northern European descent, and it tends to occur further away from the equator, and that's true both in at least the North America and Europe. But it's probably this is kind of like the typical answer when we as physicians don't know what the answer is, but it's probably a combination of genetics and environment, right? So there probably is an underlying immune genetic predisposition, which is triggered by something environmental, which in this case is probably closer to the equator rather than further away.
Would it be vitamin D?
I mean, who knows? Vitamin D has been implicated in MS, and it's probably
Yeah.
not that far along to be implicated in MG as well.
Something for some PhD student to look at, I suppose.
Absolutely, not a bad idea for a thesis, right?
And why is it so aggressive, the MUSK antibody?
Yeah, the MUSK antibody, it tends to, as I mentioned before, have a proclivity for attacking the bulbar muscles. And when bulbar muscles are affected, people in particular can develop severe dysphagia. And when they develop severe dysphagia, obviously that puts people at risk for aspiration, puts people at risk for then respiratory failure, pneumonia, et cetera. And so it's interesting. I've seen a few cases of MuSK-MG where, they look like very, very severe bulbar ALS patients, but when you treat them, it reverses, quite nicely. And, it's important to make the diagnosis of MuSK myasthenia, not only because of the severe nature of it and the urgency to treat, but also it's quite a bit different in terms of its response to therapy. So MuSK myasthenia, for example, responds beautifully to B cell therapy, such as rituximab, whereas it doesn't respond as well to some other therapies like pyridostigmine, for example, and it tends to be less responsive to treatment with things like IVIG or conventional immunosuppressants.
And you said it's not associated with thymic disease, unlike, say, the acetylcholine
Correct.
antibody. Okay.
Yeah, that's been shown, over and over again. I mean, I'm sure you'll find a case here and there where it was, shown to be associated with thymic disease, but by and large, it's not. That being said, I still do, despite the fact that I was involved in some of this research, if I make a diagnosis of MuSK-MG, I still do a chest CT. It's a low
Just,
risk procedure, and just to be on the safe side.
but you wouldn't send them on for thymectomy like you would with anti-acetylcholine receptor.
Correct. Unless I found a thymoma, I would not send them for a thymectomy. Right.
And that brings me to something that I have seen in my practice is somebody who has had thymectomy and still kind of the myasthenia persists. And that's a chunk of the refractory group. Where are these antibodies coming from? If you've taken away the thymus, and that's where we think or at least I thought that was where the antibodies were coming from.
Yeah, no, likewise. I think, don't get me wrong. I mean, I think thymectomy can help many patients, but I've seen it, in my practice as well, where you send a patient for a thymectomy and you hope that it really kind of solves the problem or helps solve the problem. And, lo and behold, a year or two, 3 years later, you're still, where you were. I mean, there are probably peripheral centers of antibody production, lymph nodes, for example, and other immune organs. But yeah, no, I think my experience is the same as yours, where there are patients that, despite taking away that thymoma in some cases, it just doesn't cut the mustard.
Yeah. A lot of head scratches with myasthenia.
Absolutely.
It just occurred to me, talking about refractoriness, is it likely that the use of steroids contributes to refractoriness? Is it going to kind of change the receptor?
Yeah. I I don't think that's been shown, right? I mean, I think that, honestly, steroids are probably they're the best and the worst drug for myasthenia. And so what I mean by that is if steroids had no side effects, we wouldn't need all this innovation that we've had, right? Because they actually do work for myasthenia. I mean, the problem with steroids is, as you well know, is just the myriad side effects that will occur, not if they'll occur, it's when they'll occur and which ones will occur. So steroids can certainly worsen MG early on if you put people on high dose, but over time, there's no evidence that I'm aware of that they actually increase the likelihood of refractoriness.
And do you opt on the long term for alternate day therapy over daily?
I've tried that in patients, and I anecdotally haven't seen a big difference. I do that in some patients, but I'll tell you, a lot of my patients, especially older patients, have comorbid conditions like diabetes. And what I've seen with alternate day dosing is it really causes massive fluctuations in their sugars. So in those cases, I'll just slowly wean on a daily basis.
And you talked about the steroid dip, which is people's myasthenia getting worse when they are started on steroids. Is this unique to myasthenia, or do you haven't come across it, or it's not been raised with other autoimmune diseases where you start steroid treatment and people get worse first before they get better?
Yeah, no, like you, I'm not aware of any other autoimmune disease where that occurs. And the theory behind it is that steroids in and of themselves actually have neuromuscular blocking effects. And the theory goes that, in the first 10 to 14 days, if you put a patient on high-dose corticosteroids, those neuromuscular blocking properties actually outweigh the immunological benefit of steroids in the case of MG. And so that's why if you're going to start a patient on high-dose steroids, you should probably hospitalize them or pay very, very close attention to them because you could potentially put them into crisis. I rarely, if ever, put people on high dose to start. I'll typically start them on a dose of like 20 milligrams per day and then slowly taper them up to the goal dose so that avoids that initial worsening.
Makes sense. Then we've talked about acetylcholine receptor, MUSK, and then this LRP4, which is, I think, kind of the third in line. Are we expecting to see more antibodies and therefore shrinking this seronegative group where no antibodies are found?
Yeah, I think so, right? I mean, as you point out, I mean, we have a population of patients that have none of those antibodies. It's probably about 7% or so, we think, of the entire population of patients with MG. And I think there's one of two possibilities in that population. Possibility one is, as you said, there's a yet to be identified antibody or antibodies that are pathogenic. Or the other possibility is that they have acetylcholine receptor antibodies, but the assays that we have aren't sensitive enough to maybe pick up low titers or something like that. So I do think that we will see a day where we can say that quote unquote 100% or near 100% of patients have an identifiable antibody.
And then the use of cell-based assays, which are more sensitive at picking up the antibodies. Is that routine now, or does a clinician have to kind of request specifically for cell-based assays? I suppose.
Yeah, it's got to be requested. Yeah, so I will send those only if patients are seronegative, have positive electrophysiology, specifically single fiber EMG, and I really want to know what their antibody status is because antibody status plays a role in what kind of treatments you can offer patients based on what's been approved in different populations.
Like you mentioned single fiber EMG, which not being a physiologist, something I find difficult to conceptualize. I've read it, I've seen the images. Why is it so sensitive for myasthenia? Why is this particular neurophysiological test so sensitive?
Yeah, I mean, basically what you're looking at in single fiber EMG are two muscle fiber pairs from the same motor unit, and physiologically they should fire just about the same time. When they don't fire at about the same time, which we can see with single fiber EMG, that indicates there's dysfunction of the neuromuscular junction, so long as other causes have been ruled out. And so it's a very, very sensitive, very specific test well, it's not specific, but you have to rule out other causes first. Once you've ruled out, let's say, motor neuron disease polyneuropathy, then it becomes pretty specific as well. But it's really the test of choice when you strongly suspect a patient has MG, but you can't find positive serology.
Okay. And does it disappear on treatment? I suppose it.
Yeah, there's some great publications on that really show it's probably is the best biomarker actually in MG. It's just not practical to do it on patients over and over again, especially if you're not in a large academic center. But yeah, with treatment, what's called jitter, the abnormality in single fiber EMG should repair.
A couple of clinical questions. One was one of the symptoms you listed was orthopnea, shortness of breath lying down. Is that to do with any weakness of the diaphragm, or is there some other reason why that is a symptom in myasthenia?
Yeah, that's not unique in myasthenia. That's actually something that we can see pretty much in any neuromuscular disorder causing diaphragmatic weakness. And it's really, it's physics, right? So if you think about it sitting up or standing up, gravity's helping our diaphragm pull down. Whereas if you're lying down, we lose the ability of gravity to help us out there. And that's, just enough sometimes to tip the balance where people may not have shortness of breath sitting up or standing up, but the minute they recline or lie down, when gravity is no longer helping pull that diaphragm down, they really experience orthopnea.
I can imagine that causing confusion in a clinic where you expect dyspnea on exertion with fatigable weakness, and the patient will tell you they have weakness at rest, I suppose. You have to be,
Absolutely.
have to be very
Yeah.
specific with the question.
Yeah, and it's important really to kind of make sure you contextualize it too, because, taking an even broader picture, I mean, common things being common, orthopnea is more likely to be something going on with the heart or the lungs, right? So it's important to keep that in mind as well.
Good. And classification of myasthenia, you mentioned the Myasthenia Gravis Foundation of America classification. I tend to be more of a lumper than a splitter. Why is it important to classify myasthenia? Is that for research purposes, or do you think a clinician should kind of in the clinic also do that?
I think it's more important for research purposes, to be honest. I think where it comes helpful clinically, as with any really other outcome measure or classification, is really justification for treatment. So, for example, here in the States, we have to make a pretty significant justification if we're going to accelerate therapy to an expensive medication. And a lot of times the payers, the regulators want to know, well, how bad is this patient's MG? Tell us what their MGFA classification is. And if I can say they're severe, they're a 4, they might say, okay, then we'll approve this medicine. Whereas if I say they're a 2, they might say, well, that patient's not severe enough. Let's try something else first.
Okay. And CT or MRI? CT has been conventional for checking the thymus. Is that kind of still the case, or does MRI have any advantage if I have a choice?
Not that I'm aware of. I mean, I think that, both are equivalent. I mean, I routinely send patients for CT scans of the chest, and you don't have to give contrast to look for thymic abnormalities. So if people have, contrast dye allergy, it's a moot point. So CT's, it's much easier for a patient to tolerate too.
Um, and I mean, thymectomy is kind of done now, whether there's a lesion, but there are also class of people that do a thymectomy, even if there's no abnormality. I suppose these are usually younger people with positive antibodies.
Yep,
Why
that's right.
does it, yeah. So why does it take up to 3 years? Because that's the age, that's the length of time it takes to get the maximum benefit. Why that long before you get the benefit of taking the thymus gland?
It's a great question. I think you can't really invoke circulating antibodies after thymectomy because, I mean, those should be gone after about 2, maybe 3 weeks max. So, we've got a couple other years and several weeks to kind of make up for. So I think that goes back to what I'd said before in terms of, peripheral generation of antibodies. And in some patients, they persist, as we talked about, and in some patients, they desist, and patients can have an improvement. I think, in my experience, yes. I mean, we typically say wait up to 3 years to see the full benefit. But I would say, get a sense of what's going to happen at that 1 year point. Again, why it takes a year, who knows? But I generally have a sense if patients are starting to improve or if they're just persistently symptomatic at that 1 year point, how beneficial the thymectomy was.
Okay. And going back to the classification, is there a cutoff where you say this at a certain time, this patient is refractory, I need to do something different?
No, I mean, I think that, and I'll answer this question in two ways, right? I mean, I think that, determining whether a patient's refractory can take a month, it can take several years. It really just depends on, how soon those people fulfill the criteria that we kind of outlined, right? On the other hand, I would say, I typically don't wait for a patient to become refractory, quote unquote, before I change my mind about a therapy. If a patient has uh, persistent, symptoms that maybe don't qualify as refractory. I'm thinking about what's the impact of the symptoms on the patient's daily life. What are the impact of any side effects on the patient? And making adjustments to therapy before they get to that refractory point.
You don't want to reach the threshold. You kind of.
Exactly.
And what's your strategy when you now define this patient is refractory? Do you still go through a hierarchy of treatments, or do you individualize what you use for a specific person?
Yeah, I think, that brings up a good point. I mean, I think that there's really, there's a general algorithm to treat myasthenia gravis, but I think as with any disease, you have to take other factors into consideration. You have to take into account patient's age, patient's, medical comorbidities, their other medical conditions, patient's choice, right, for, how acceptable or unacceptable are these symptoms, different routes of administration, different dosing schedules. So that's the great thing about a disease like myasthenia is that, if it was simple, a simple recipe, I mean, you wouldn't need me to do it. You could have my 17-year-old daughter do it reading a book. But the cool thing about it is actually, having to use your medical knowledge, your general medical knowledge, your neurological knowledge to really kind of tailor, your therapy to that particular person.
And you mentioned eculizumab. How much is that now part of your practice? Do you use that quite a lot?
So it's interesting. So eculizumab was approved in the U.S. in 2017, and then a couple years later, ravulizumab came along. So it's the same company that makes it. They just engineered eculizumab to have a 4 times as long half-life. And so yes, I used eculizumab early on, but when ravulizumab was approved, I changed patients to that because it allowed for every 8-week dosing as opposed to every 2-week dosing. So it's much more convenient for patients. And so I do have a percentage of my patients, granted it's a small percentage, but it's a decent, small percentage on complement-based therapy, specifically ravulizumab, patients that did not respond to earlier lines of therapy.
And where do you plug in things like IVIG and plasma exchange? Do you just use them for people in crisis, or do you use them to augment treatment of refractory myasthenia?
Yeah, so I'll start with IVIG. So IVIG, I'd used both chronically and acutely in the past. I mean, I still use it acutely if patients are experiencing a worsening that might not require hospitalization. If a patient requires hospitalization or is in crisis, then that's when I use plasma exchange. I've not used a lot of IVIG for chronic treatment in myasthenia since the approval of efgartigimod and rosanolixizumab, which are fetal neonatal receptor antagonists, simply because I think that those agents work a little bit better in terms of efficacy. They're more convenient for patients and they're much better tolerated in my experience than IVIG. So I've largely supplanted the use of IVIG with the fetal neonatal receptors, antagonists rather.
And probably the last clinical question, how do you monitor your patients? Do you bring them to clinic regularly, or do you have an outreach team? What's your strategy? Because monitoring is kind of a big thing with myasthenia gravis.
Yeah, it's a combination of all of the above. I mean, I think it really depends on where a patient is in their journey with myasthenia, how well controlled they are. So, very, very thankfully, on one end of the spectrum, I've got patients who are in remission, who have been in remission for years, and I see them about every 6 months just to check up on them, make sure they're doing well generally, check their lab work if it's necessary based on what they're on, and really just kind of check in on their lives. In patients that are more recently diagnosed, more severe, experiencing challenges, I may see them every 4 weeks, just because it's such a significant disease and you've really got to act quickly with this disease to prevent things like hospitalization. And so that's not a lot of my patients, but it's many of my patients. And obviously there's touch points in between with the nursing staff, my assistant and whatnot. How I monitor them in general is good old-fashioned medicine, talking to the patient and examining them. But myasthenia is unique in that it's fluctuating, so it's important not only to ask the patient what's happening right now, but kind of take me back over the past week, the past month, et cetera. And using things like patient-reported outcome measures, things like the Myasthenia Gravis Activities of Daily Living Scale, which was initially developed for research purposes, but can be very useful in the clinical setting. It allows patients to really track their symptoms, and it allows me to understand what's happening over the course of several weeks or months in between clinic visits. And really, it's using a holistic approach to determine how well a patient's doing and if we need to make a change for whatever reason.
And are there we talked about looking for better biomarkers. Are there any on the cutting edge of research that we're looking at for
Not
myasthenia?
that I'm aware of. I mean, we talk about this so much that I have to imagine that someone in their lab is looking at this now. I have to hope. I've not been privy to any of those conversations, but there's a lot of people that are a lot smarter than me with hopefully some good funding that will figure this out sometime soon.
Okay, we'll keep our fingers crossed. What are there any major uncertainties in the field? We've kind of covered a few, but what would you say are the major uncertainties or big questions in myasthenia?
Yeah, I mean, I think we covered a lot of ground on that already, but I will say, somewhat redundantly, that I think, we need to get a little bit better in terms of personalized medicine. And what I mean by that is if we had, demographic features, a biomarker, or something along those lines that allowed me to predict a priori, this patient will benefit from this medication, that will get that patient under control faster and, prevent them from experiencing any side effects on medicines that may not be optimal for them. And I think we'll probably see that in many diseases as time goes on, but I think we can probably realize it in myasthenia sooner. And then I think, another big question is, why do people get myasthenia to begin with? We touched on this a little bit before. Patients, especially the older patients, ask me, well, how did this happen? And, obviously I say we really don't know, and I, kind of give them the spiel I gave you before. But what's really interesting to me is, why does a patient with a proclivity for this disease develop it at 70 and not 30? And some people develop it at 30 and not 70. So these are some unanswered questions that I hope to be able to know in my lifetime.
I might bring you back when you revise the book, and maybe
Great.
things will have changed by then. Okay, I would just want to pin you down. What 3 key lessons would you want a reader to take from the book? I know we've kind of covered a few things, but what would you say you put right at the top?
Yeah, I would say right at the top is it's important to really talk to your patients, and it's important to really understand how the disease impacts their lives, because I think that it's if a patient comes in and says they're doing good in the context of a busy neurology practice, that's great, right? And I just want to move on. But I think it's important to probe patients to really understand how the disease affects their day-to-day life, because patients with myasthenia, we can get them better than they were, but I want to get my patients with myasthenia their best. I want to get them to really know symptoms and really know side effects of their medicine, and that's my goal. And in some patients that takes a little bit of time, and in some patients it takes a lot of time, and in these refractory patients it can take a whole lot of time, but it's very rewarding at the end. So I think, the first and foremost is talk to your patients. Secondly, I would say it's really important to tailor therapy, to not get into a rut in terms of an algorithm or a recipe. And it kind of goes hand in hand with my first comment, really talking to people, getting their input, what we call shared decision making when it comes to choosing therapies. And thirdly, I think, I would talk about, or I would stress the importance of making an accurate diagnosis. So, sometimes people may present with mild symptoms or vague symptoms that initially don't sound like myasthenia. Or conversely, sometimes we think a patient has myasthenia and they don't. So I think really, checking for antibodies, doing electrophysiology, leaving no stone unturned is also important.
Perfect. Okay, thank you very much for that. You've talked about other books you've kind of contributed to. Do you have any other book where you're kind of any book in the works, or any other books you've published that you kind of want to highlight?
Yeah, so I did publish a book a couple years ago, which was a signs and symptoms approach to neuromuscular disorders. That was a work I collaborated on with many of my colleagues, and it really talks about a lot of ways that patients might present to you, and how to kind of go about that differential diagnosis to institute treatment. So neuromuscular disorders, a signs and symptoms approach, is what it's called. And in the works, nothing in the works right now, but certainly as things evolve, I could definitely see myself contributing again a little bit more to the literature.
Okay, I look forward to that. And what's your current research in myasthenia? Any particular projects you're in?
Yeah, right now I'm kind of focused in on the burden of treatment, really specifically with steroids and other agents that have been conventionally used, as well as healthcare economics in myasthenia. Really looking at what does the disease cost the healthcare system, and should we be treating these patients more aggressively out of the gate to really kind of help save cost over time and really lead to better quality of life in patients.
Okay. That sounds beneficial.
Thank you.
Okay. Nicholas Silvestri, thank you very much for your time today. I'm very grateful that you've spared your time and gone back over the topics in the book. And to my audience, thank you very much for joining me. If you found this interesting, do check out Nicholas's book, and then you can check my own book called Surfing the Brain. And I have a website called Neuro Checklist if you want to check out a few things on neurology. And to make sure you don't miss the next episode of the podcast, why not subscribe to the iTunes, YouTube, or Spotify channels? Until the next time, however, thank you very much for your time. And Nicholas, I'm very, very grateful. Thank you very much.
Thank you.